Good evening, one and all. I'm Dr. Vijay Kumar Chennamchetty, lead interventional pulmonologist from Apollo Group of Hospitals, Hyderabad, and also webinar coordinator. Today's webinar moderator. Okay. Generally, I feel very elated, excited to moderate any session of CCI webinar. But today, you may wonder really, okay, why Dr. Vijay Kumar is appeared in CCI webinar with a black shirt on an Independence Day, 78th Independence Day. The reason is, I know today the topic is airway foreign body, but the reason for this silent protest today is, it's with whole lot of immense grief, dukh, annoyance, lot of difficulty feelings from deep inside. I'm reading a message from our founder, chairman, trustee, Dr. N.H. Krishna Anna. CCI expresses immense sorrow and grief regarding most unfortunate incident where we lost a daughter of our medical fraternity at Kolkata for a heinous crime. We at CCI, over 3,000 pulmonologists, demand immediate justice to the lost soul and bereaved family. She belongs to pulmonary fraternity, second year postgraduate. We also strongly demand immediate and serious action to be taken against the culprits. We also strongly insist upon tightening up and enhancing the security to the all on-duty medical officers across the continent and also paramedical staff. Because if we are allowed to do our work safely, securely, we can do really wonders. Otherwise, lot of young talent, the budding generation, next generation, who are aspiring to be doctors, they are really scared to just even opt into MBBS profession. My soul is weeping relentlessly since the brutal attack which resulted in death. This is a disturbing reminder of growing violence against healthcare professionals in India. Hospitals, they are related to temples which are meant to healing and caregiving. They should not turn into battlegrounds for violence and intimidation. Really, I am telling, if you want to, this subcontinent, or to be honest, from this subcontinent, majority of doctors are spreading across the world, okay, and providing healthcare across all the continents, across the globe. So, if these kind of incidents continues, it becomes very, very impossible task for these young minds to take it to professions, into this profession, and we will be losing lot of good talent not joining into medical profession, and it is our duty, particularly government's duty, to provide security at every level while they are in duty at least. This message from my team is straight to our Prime Minister's office to take immediate action to bring in corrective steps to prevent such activities in future. let me start to focus on today's airway foreign body webinar. Foreign body aspirations, they are fourth leading cause of death in preschool and young age children and accounts for significant emergency department visits in both young age children and also in elderly. There were very few preventive measures in place, like labelings with warnings on small pots which are used as a toys, and warning on choking episodes of other small particles or objects. I must tell you, all the social media presence of this awareness on foreign body aspirations is very minuscule. Public education is really, really important. On this Independence Day, let's aspire and put it into practice on behalf of CCI to prevent foreign body aspirations across the globe, particularly in India. So, thus, public education is very, very crucial. Without further delay, I would like to invite my dear esteemed panelists. In this subcontinent, Atidhi Devo Bhava, our guests are God. And today, we have the eminent faculty across India. Our guests are here, first of all, Dr. Nikhil, a wonderful person, eminent expert radiologist when it comes to thoracic radiology. So Dr. Nikhil names comes next only to Bhavin Jankaria across this subcontinent. Dr. Nikhil, welcome on board, and we look forward to have very expert opinions and views on this topic. Dr. Vijay Kanth, sir, another expert from anesthesiology department. Sir has got a 21 years plus experience in the field of anesthesia, especially pediatric anesthesia, he is associated with treatment of cleft society since 18 years and anesthetized more than 8,000 cases of cleft lip and palate. And currently, Dr. Vijay Kanth is working as a head of the Department of Anesthesia and Critical Care with Omni Super Specialty Hospital, Vishakapatnam, Andhra Pradesh. He is a good friend of Dr. Bala, Raju, Tadikonda. Thank you, sir. And another important guest today is Dr. Sukhram. Dr. Sukhram is a good friend of us. He's a leading thoracic surgeon and transplant surgeon. Recently, I think a year back, he acquired his skills of transplant, lung transplant from Toronto General Hospital, Canada. Currently, he's working as a senior consultant with Medanta, Gurugram. Welcome, Dr. Sukhram. And coming to our fraternity, close to around 20 years friend, my good friend, Dr. Bala, Raju, Tadikonda. So his passion towards foreign bodies was really contagious. I'm sure in this, at least in southern India, he is one of the topmost bronchoscopists, currently working with at Gayatri Chest Clinic and at Vishakapatnam. And welcome, Dr. Balaraju. And coming to Dr. Venkat. Dr. Venkat is a good friend of mine. I know him personally for the past 10 years. currently heading the Department of Pulmonology, professor at SVS Medical College, Mehboob Nagar, and also practices in Hyderabad. Welcome, Dr. Venkat. He is another leading foreign body specialist, both in neonatal bronchoscopies. Dr. Venkat is the known name in Telangana. Welcome, Dr. Venkat, Dr. Venkat Tummuru. And last but not least, Dr. Samir Kotalwar, good friend of mine, is a senior pulmonologist, experienced bronchoscopist from Nanded. Welcome, Dr. Samir. I would request each one of us to pay silence for at least a minute till I say to go, and then I would come and introduce the topics of today's discussion. I request everyone to pay silence for 1 minute. Thank you. Our prayer from CCI is, let this soul reach lotus feet of Almighty. And dear hundreds of delegates across the country, today's flow is first topic by Dr. Nikhil. He speaks on clinico-radial aspects of airway foreign body. Second topic is from Dr. Raju Tadikonda. You cannot afford to miss this topic because today he is going to give his 15 plus years of experience in airway foreign body management and how to establish a comprehensive suite for bronchoscopic suite for foreign body retrieval. Third topic is by our beloved thoracic surgeon, Dr. Sukhram. He will share his experience of role of surgeon in airway foreign body management. Please do post your questions, queries, whatever dilemmas that may be silly for you, that will be very, very important for others. And it will help us to discuss and dissect this topic further. My request is, please participate actively, post your questions. We'll be looking forward for taking your questions, my dear friends. And without any delay, I would request Dr. Nikhil to go on and present his topic.
Good evening, everyone. First of all, I would like to thank Dr. Krishna and CCI family for having me here. Thank you, Dr. Chennamchetty, for such a nice introduction. I am Dr. Nikhil Gupta, and I am a consultant at SPS Hospitals, Ludhiana. Let's start with this talk on radiological assessment of airway foreign bodies. This talk is divided into two parts, children and adult. So the mechanism of obstruction is generally obstructive emphysema. So air goes in but does not leave. So this is the main mechanism, and it is most common in children. The less common mechanism, that is obstructive atelectasis, in which air does not enter, air does not leave. So this is more common in adults. The least common is normal aeration. That is, air comes in and air goes out, causes partial obstruction. On radiograph, in expiratory scan, we can see hyperinflated lung on the affected side. Also, there may be signs of atelectasis or infection on the affected side. Fluoroscopy can also be done if radiograph is inconclusive. Generally, a low dose CT is recommended. So, CT is also done in assessment of retained or missed foreign body. This is the best investigation that is there, non-invasive. First of all, the foreign body goes into the pharynx and then it may be aspirated or goes into the esophagus. This slide is only there to differentiate between the coin and a coin battery. The coin battery will have two indentations and it will have a structure like this, a small circle and a big circle, like this and like this. So this is very important because these are dangerous and may cause perforation of the structure in which they are lodged. So foreign body can be sharp also, like this, a hook, and if it is not accounted for, or it can lead to further damage. Then this is a case of a patient choking on nuts. The left lower lobe bronchus had the foreign body, and this lung is hyperinflated. And on expiratory scan, we can see air trapping. This is a complication of foreign body aspiration. In left lower bronchus, the foreign body was dislodged, which was taken out. It was an almond, but patient after that got recurrent infections, and when further CT was done, then bronchomalacia was the culprit in this case. Coming to ultra low dose CT, uses a tin filter, reduces the risk of misdiagnosis, and it uses equivalent radiation to the chest radiograph, that is around 0.04 to 0.06 millisievert. You can see the picture quality is good, and you can easily see the foreign bodies here and here. In adults, the foreign body can be introduced by aspiration, ingestion, trauma, accident. They may be intravascular or hydrogenic. Airway foreign body, the factors that predispose are swallowing disorders, neuromuscular or neurological disorders. While the esophageal foreign body can present with chest symptoms like pneumomediastinum, pneumothorax, pleural effusion, or mediastinal abscess after perforation. So these are also important. Then coming to imaging techniques, more or less the same. In addition, MRI, which has generally a limited role. So in peanuts, due to their typical fat signal intensity, it is helpful. In adults, the air trapping is less as compared to children. Atelectasis is more common. And in adults, the bronchus intermedius is more common location, while in children, central location, generally left side, predominates. So foreign body is generally lucent, as we discussed. More than 90% are lucent. If it is radiopaque, then very easy to diagnose. Bronchiectasis and bronchial stenosis are late complications, while obstruction signs of obstruction as air trapping, subsegmental atelectasis are seen on chest radiographs are the only signs to show a radiolucent foreign body. So strong suspicion is required. Then this history is important. This was a case in which there was a pin in the right lower lobe and the patient was schizophrenic. This is a case, the history is unknown. A cross was there in the bronchus intermedius. This is another case in which the patient was IV drug abuser and this expiratory scan showed air trapping on the right side, which on CD showed a rounded tubular foreign body, which was a plastic tube. This is a case showing a coin. The patient, after taking alcohol, he participated in a contest of throwing coins and catching them with the mouth. So this was lodged in the hilum. First, it was thought it is a esophageal foreign body. Now, as we can see here, in this patient, there is air trapping on the left side with bronchiectasis and something lying within the bronchus. So on bronchoscopy, it was found to be a small part of a vessel. Okay, this is a case after an accident. The patient aspirated this piece of wood, which can be seen here, and this is a part of consolidation or collapse in this lung. This was a case in which after a gang assault, there was there was a foreign body in this lung, which was actually a part of a broken bottle, which was in his back and in the lung parenchyma. So glass looks more radio opaque. This is a shrapnel from a accidental explosion of hand grenade. This is a case showing stones within the stomach and the right lung with collapsed part of the right upper lobe. So this was a case of gas explosion, gas line explosion. This was a schizophrenic patient with vague chest symptoms. There was multiple mutilation attempts. This was an opacity in the right lower zone, which on CT shows a nodular opacity surrounded by low attenuation material. At thoracotomy, a pencil was obtained with surrounding dense inflammatory tissue. Let's skip this. This is a case which this person underwent pericardiectomy for pericarditis 20 years ago, and this was a retained gossipiboma. So retained sponge. This was a case which underwent TB treatment with paraffin wax known as plumbage a long time ago. So this is fat density in the right upper lobe. This is a case of esophageal speech device which went into the carina, and we can see it is lodged here. Then this is a case, interesting case of foreign bodies. These are small gold acupuncture needles, and these also went into the lung parenchyma. This patient had chronic backaches. This is a IV drug abuser, and you can see these opacities, linear opacities here. And on this close-up view, we can see them clearly. This is these represent mercury droplets, which form a part of IV administered drug mixture. So this is a rare case of an intravascular foreign body. These got dislodged into the heart. So thank you everyone for your patient listening.
Good evening, all. Thanks for the kind introduction. That was a nice topic, Dr. Nikhil. So let me thank Dr. NH Krishna and the entire CCI team for giving me an opportunity to speak here. So what we're going to do in another 15 minutes time is to briefly talk about how to set up a bronchoscopy for airway foreign bodies. So this is my agenda for today. So we're going to briefly talk about the instrumentation. There are flexible and rigid bronchoscopes and their accessories, flexible and rigid accessories, and also very briefly about jet ventilation. So these are the topics I'm going to cover in this 15 minutes time. So coming to the instrumentation, the first one is the bronchoscopy. We need to choose the bronchoscope to extract airway foreign bodies. So we have two types of bronchoscopes. One is the flexible bronchoscope and the rigid bronchoscopic system. So we're going to focus first on the flexible bronchoscope. So we all have this flexible bronchoscope. What we have is a 6 mm and 2.8 mm diameter bronchoscope. So this is very good to perform bronchoscopy for adults, but it is not so great tool for performing foreign body aspiration in the pediatric population. So most of us will be having this 2.8, 1.2 mm bronchoscope. This is good enough. But if you ask me which is the best two bronchoscopes available for foreign body extraction, are these two bronchoscopes. So one is the 4 mm 2 mm bronchoscope and another is the 3 mm 1.7 bronchoscope. So what is the greatest difference between these two types of bronchoscope? One, when you have a channel with the 2 mm working channel, most of our accessories are designed for 2 mm working channel. So most of our accessories will go in this 2 mm working channel. And if you keep the outer diameter of the bronchoscope less, it's high chances that you can pass this bronchoscope in different endotracheal tubes, and also you can perform in pediatric population. In the same way, if you use a pediatric bronchoscope, that is a 2.8 or a 1.2 or a 3 or a 1.7, so you can pass your 1 mm accessories, and also you can perform in neonates are also less than 2 years of age. So what are the flexible bronchoscopic accessories we need to focus? The first accessory is the basket. So this is the most important accessories what we need to gather to perform a foreign body aspiration. First is the basket, next is the balloon, and next is the forceps. So if you have these three instruments in your hand, you can do more than 90% of the foreign body cases. And also if you have a cryo, in difficult situations, you can do foreign body aspiration with a cryo forceps. And also other miscellaneous like tri-prongs, grasp with forceps can be useful, but not helpful in all the cases. So coming to the accessories, so this is how you need to use a foreign body basket. So what you need to do is to pass distally the basket, inflate it, open it, and try to engage the foreign body in the basket. And another is forceps. So when you use the forceps, make sure that you are holding at the sharp end of the foreign body, and make sure that you hold the whole cup so that you will not slip the foreign body. And when you're using the balloon, make sure that you pass the balloon distally of the foreign body, inflate the balloon, and you can dislodge the foreign body proximally. So once you dislodge the foreign body, you can easily extract with either with a basket or a forceps. So balloon is not a great tool for complete extraction of a foreign body because you will not have good grip at the trachea and the subglottis. So coming to the cryo, so cryo is used when you have an foreign body with organic foreign body where a water content is available. So what you need to do is to go on top of the foreign body and activate the cryo so that the foreign body is freezed to the cryo probe, and you can extract the foreign body in one go. So coming to the different types of baskets, so what we have is the normal 4 mm nitinol basket. This is what we have. So we already saw how to deploy the basket and extract the foreign body. So there is another basket called proximal opening 1 mm basket. So the advantage of this basket is you can open the basket proximally, engage the foreign body and extract it. So you can see there the basket opens proximally, you engage the foreign body. So once you engage it, you hold the foreign body, then you can extract the foreign body. So these are the different types of baskets available. So coming to the balloon, so we already saw how to deploy the balloon and extract it proximally. But if we have a specific types of foreign body, this is a pearl bead. So where there is a hole at the center part of the foreign body, so you can pass a balloon distally through the whole of the foreign body, inflate it and proximally pull it. So that's what we're going to see here. So that's the foreign body in the right main bronchus. So you're passing the balloon within the whole of the foreign body, inflate the balloon, and you can extract it. So these are the uses of balloon. So coming to the cryoprobe, as I've told you, when you have an organic foreign body with water content, you can freeze the foreign body with the cryoprobe and extract it. And also, excuse me, also it is useful for mucous blood clots also. When you have an organic foreign body, it will be easy to extract with the cryo. So coming to the rigid bronchoscopic system, so this is the previous system where it was difficult to perform. These are called the Chevalier-Jackson rigid bronchoscopic system. So this is how it is. So you have a fiber optical guide. This is called as distal illumination. So this is the bronchoscope. So we need to see from the proximal part of the bronchoscope. So that's the proximal part. So you need to see within the lumen of the bronchoscope. So that's how it's going to look within the bronchoscope. So this is a very, very narrow pinhole vision. But the problem is once you pass the biopsy forceps inside, it is very difficult to visualize. Whereas today's systems, they are different. You have a telescope which can be passed through the trachea, and you have a magnified image in the monitor. And also when you combine the telescope with an optical instrument, it is called an optical forceps. You can visualize the foreign body and hold the foreign body with one single hand. So that's the greatest advantage with the current systems. That's a newer rigid bronchoscopic systems. So this is how a new rigid bronchoscopy looks. This is a pediatric storage rigid bronchoscope where you have proximal part and a distal part. This is a hollow cylinder where you have vents at the distal part for cross ventilation. So there is a proximal part and a distal part. So these are the few accessories for the rigid bronchoscope. So this is how it's going to look. The proximal part, you can use a prismatic light deflector for visualization. That's a light source. So that's the working channel. It can be covered with a cap. And this channel is for the jet ventilator adapter. And this channel is for the pain circuit. So as I've told you, if you combine the visualization with the forceps, now this is called an optical forceps. The greatest advantage is you have vision and forceps in one instrument. So you can perform the procedure with one single hand. So there are different types of optical forceps. We have full peanut, half peanut, and artery forceps. We're going to just briefly go through each and every instrument. So coming to the artery optical forceps, so this is basically used for hard foreign bodies like seeds, plastic objects, and steel foreign bodies. So the greatest advantage you can see you can see that serrated hooks at the cups. So it offers a better control of foreign body. And you have one more forceps called a peanut forceps, where you have a cups. In the previous optical forceps, you have a serrated tooth, whereas this one will have a cup. So this can be used for soft foreign bodies like peanuts. Okay. So this is how we assemble the rigid bronchoscopic system. Now it's not the my point of discussion now, so that we can see it in any of the workshop if we attend. So this is how we assemble the rigid bronchoscopic system. So this is how the complete rigid bronchoscopy after assembly. So you have a rigid bronchoscope with a bridge connected to a telescope to the camera. So that is the light source for the bronchoscope, and this is the light source for the telescope. So this is a brief video of how do you intubate with the rigid bronchoscope. This is Dr. Vijay sir giving anesthesia for this child. So this child was sedated and paralyzed. With the help of with the help of laryngoscope on the left side with the left hand, I was able to pass the rigid bronchoscope through the vocal cords. So once we pass the rigid bronchoscopy through the vocal cords, we can visualize with the camera which is attached there, so that the jet ventilatory cannula has been connected. So you can see that Vijay sir is performing jet ventilation with the rigid bronchoscope. So there are also adult rigid bronchoscopic system, almost similar to the pediatric ones, and you have a larger optical forceps, so where you can extract tougher foreign bodies, and you have a largest 4-wire basket where you can able to grasp large foreign bodies. And briefly about ventilation, so you can perform with ambu bag ventilation or a vein circuit ventilation. Dr. Vijay sir is going to discuss about that in the discussion. But we generally use what is called as a handheld manual jet ventilation. So the advantage is you can do intermittent oxygen ventilation. Patient is in paralysis. The greatest advantage is you can have better control of ventilation with jet ventilation compared to vein circuit. So what we have discussed was types of bronchoscope, different accessories, and how do you use those accessories. To conclude, so rigid bronchoscopy is a time-tested system. Physicians should be well versed with both flexible and rigid. So we cannot say that we will perform only with flexible. There are instances flexible can fail, so rigid will be at rescue. And the same vice versa, rigid can fail and flexible can be a rescue. For impending respiratory failure, rigid bronchoscopy is a better control of ventilation. Why? We can use a jet ventilation, whereas with a flexible bronchoscope, you can't use a jet ventilation. So each case of foreign body aspirations are unique. So follows principles for safe removal. There is no single best instrument for all the foreign body cases. So rigid or flexible, no one is superior over other. Each one can fail. Thank you for your patience listening.
Hello everyone. Thank you so much for giving me opportunity of this role of surgery in airway foreign body. First of all, I like to thanks Dr. Nikhil for giving a very good presentation on radiological finding of foreign body, and then very excellent presentation by Dr. Bala Raju for rigid and flexible bronchoscopy in airway foreign body. So my role is very limited as usual in the role of surgeon in airway foreign body. However, I would like to cover in next 10 minutes for the topics. So surgeon's role is with the emergence of IP and extensive across the country. There are lot of eminent people who are doing lot of IP. So role of surgery is actually become very limited. But it has, I would like to divide into two parts. One is the acute presentation, and second one is in the surgeon's role in the chronic presentation. So natural course of foreign body, if we look at the aspirations, it may be like the foreign body which is being exploited or swallowed and being exploited. Then the second situation, which is death from suffocation with the complete airway obstruction or reflex laryngospasm, which lead to the maybe patient have limited duration of symptoms pre-period, or patient may present with the persistent symptoms like unexplained dyspnea, recurrent wheezing, or chronic cough, or maybe something like that. So the patient who are having persistent symptoms may require the acute intervention or may require the chronic intervention, but the patient who are having chronic symptoms may lead to the complication like the acute pneumonia, recurrent pneumonia, lung abscess, bronchiectasis, or hemoptysis. So looking at the management point of view, so first of all, it is being managed by the IP people or by the pulmonologist. The surgeon is called only in rare situation, in like in acute situation where the life-threatening aspiration is there, or in the chronic non-life-threatening situation. So in a life-threatening situation where the surgeon may be requiring, first of all, is the securing airway is the first step. So it's like the when in need, we could go for the intubation. If trial of intubation is unsuccessful, then in the based on the airway foreign body, where we can divide into the things like if it is subglottic reasons, we can look for cricothyroidectomy or the emergency tracheostomy, where the foreign body is being bypassed and the tracheostomy is being placed. In the rare situation where near cardiac arrest and complete obstruction of the airway, we may have to look for the ECMO. Mostly in the, it's very rare, and availability of the ECMO and taking up the ECMO setup is very rare. But yeah, though it's the availability of the ECMO can help us. So cricothyroidectomy or tracheostomy is usually in only for the subglottic impacted foreign bodies. It's a in case where there is a doing rigid bronchoscopy or flexible bronchoscopy, it end up there is a significant glottic edema is there, and which led to the bronchospasm or something like that, or maybe the foreign body which is too big and cannot pass through the vocal cord. In those situations, if the foreign body is stuck in the subglottic regions, where we can bypass with the cricothyroidectomy or for tracheostomy as a life saving situation. ECMO, it's a very rarely required and very rarely it is available. Use of ECMO is VV ECMO. There is no role of VA ECMO in the urgent or acute situation. Now, coming to the late chronic situations where the impacted foreign body can cause the late complication, where the requirement of surgeon may be there. It's like causing the airway stenosis, which may be stenosis of trachea, which may be stenosis of the main bronchus, or maybe a stenosis of the lobar bronchus, which got impacted and long-term foreign body has caused the problem. The second one is recurrent episode of pneumonia because of the obstruction, which led to all the recurrent pneumonia, and these pneumonias are requiring the frequent hospital admissions, or maybe the requiring the frequent antibiotic, IV antibiotics or oral antibiotics. Sometimes the complete obstruction of the lobar bronchus, or maybe the main bronchus. Commonly it's happening in the left side of the left main bronchus, where the distal lung is completely got destroyed, and which is causing clinical symptoms, maybe formation of the abscess, or maybe destruction which is leading to the sun fraction, causing the dyspnea, or with the pain or something. There the surgeon's requirement may be there. In case of bronchiectasis, the foreign body, a persistent foreign body can lead to the bronchiectasis, and there the frequent antibiotic requirement can lead to the surgeon's role. Abscess, yes, and in a few certain cases like their hemoptysis is there, which can lead to the surgeon's involvement. Look at this, is the one among the foreign body which we have extracted. So bullet led migrated into airway, and the distal lung has become bronchiectatic, where we need to do the surgery. The another one is the bronchiectatic prolonged foreign body, which even after the impact, it lead to the persistent use of it's requiring the surgeon's role. Now, chronic obstructive emphysema lead to the foreign body aspirations. There, the surgeon's role is there. Sometimes that while doing the extraction of the foreign body, it lead to the complete obstruction, and there the surgeon's requirement is there. Sometimes we, while doing the bronchoscopy or rigid bronchoscopy extraction, lead to the bleeding, and then the whole lung has flooded with the blood. There, the surgeon's role may be there. And one among our cases where we had a patient who was, while being magnet was being there, and which is the being taken out in which was attempted as a taking from the rigid bronchoscopy, and it led to the tear of bronchus, and following the which we did surgery in this patient. He was a young chap. He was being attempted at bronchoscopy, and later, because of this thing, we requiring the surgery. So we did we in and we saw that they did to find out where the dissection, we were able to see it that where the magnet was impacted, it was being taken out, and then later with the proline we did the suturing, and we were able to suture with the VATS, and after the complete successful the suturing, we did the air leak test, and in air leak test we were able to find out that there wasn't any active air leak was not there. So closure was being done, and we will put the chest tube, which is like the normal course. So lung got completely expanded and the patient recover. But these are very rare situation where the while taking out foreign body, the bronchus got teared up, and then in the acute situation, if it is a patient being reported within first 24 hours to 48 hours, it has very good outcome, because there we can do the primary repair. But if it is coming late, then we may have to do the resection, anastomosis, or maybe end-to-end resection or anastomosis may be there. So here with this, I want to thank you everyone for patience listening.
What a fantastic deliberations from all the three faculties, Dr. Nikhil, Dr. Balraju, and Dr. Sukhram. Okay, it was so informative. Thank you. And now, without further delay, I would first of all love to have Dr. Venkat. Dr. Venkat, what is your take on foreign body removal? What is the technique overall? Okay, you have an exhaustive and extensive experience, and a bronchoscopist, if he wants to contemplate a foreign body extraction, what is the thought process that he should go?
So most of the times I prefer to go with rigid bronchoscopy only. Flexible bronchoscopy, as Balraj sir said, we should keep flexible bronchoscope also ready, because rigid bronchoscope sometimes it may fail and we have to do with flexible. But most of the times rigid bronchoscope, with rigid bronchoscope only it will come out. For soft foreign bodies like peanuts, better to use optical forceps with the half peanut or full peanut forceps, like seeds, either tamarind seed or most of the time sitafal, custard apple seed. Better to do with alligator or artery forceps with more tooth. And for sharp foreign bodies, mainly hold the tip of the foreign body, get the tip of or sharp end into the barrel, then only try to remove in toto. Never try to take out the foreign body initially with barrel out and followed by the foreign body out. Not better not to do that. Otherwise, we may tear the bronchus and we have to send the case to surgeon. Okay. So these are the things, but mainly for sharp foreign bodies, mainly secure the tip into the barrel, then remove it. That is the thing.
Thank you, Dr. Venkat. In addition to whatever Venkat has said, so he says definitely rigid and then flexible both are required, and then in some cases selectively rigid may be preferred. On the other hand, we must understand very clearly that any foreign body, once it is there, the first rule of thumb is to disimpact the foreign body from its position. Once you gently disimpact and then try to extract. And now I would like to take opinion from Dr. Samir. Dr. Samir, okay, in your experience, I'm sure you are one of the pulmonologists at Nanded with extensive experience in airway foreign bodies. So when dealing with organic versus inorganic tracheobronchial foreign bodies, so what is your experience, and does type of foreign body and duration matters?
Thank you, sir. Thank you for inviting me to be a panelist in this webinar. My sincere thanks to CCI Executive Body for giving me this opportunity to share my views and on this topic. So there are two types of foreign bodies, organic and inorganic. So organic foreign bodies like food particles like seeds, nuts, popcorns, carrots, and fruits and vegetables like cherry pits, then orange peels or potato chips, then meat and bones, seeds like peanut shells, then walnut shells, and other like mm, some cotton balls. Then these organic foreign bodies are biodegradable. They can break down over time, and they may cause inflammatory responses, causing inflammation and infection. And they can be of variable sizes, small or large. They may be soft or they may be hard, and some and other type is inorganic, like coins or batteries, that is button cells or alkaline cells, then toys or small objects and metal fragments or glass fragments or plastic one. So these are non-biodegradable. These have corrosive potentials and may cause chemical burns, and they can be of various size and shapes, and they are usually hard. So duration, it really matters, sir. In acute aspiration of these foreign bodies, so short-term aspiration can cause sudden obstruction, leading to respiratory distress, choking, or even death. And in chronic aspiration, that is long-term aspiration, it may lead to chronic inflammation, then scarring or respiratory distress. So there is a
You mean to say that the entire presentation of acute and chronic and the duration definitely matters, and then whether it is organic or inorganic is going to play a very crucial role. Okay, in management of airway foreign body. Thank you, Dr. Samir. And I would now like to take the opinion of Nikhil, Dr. Nikhil. There are possibly some reasons that imaging may not be revealing the foreign bodies on particular imaging. What is that such crucial scenarios? How would you like to take it forward?
So 40%, around 40% foreign bodies are not visible on X-rays. Even in some CTs, we can miss the foreign body. We can also miss the foreign body in CT. So we have to rely on the secondary factors like emphysema, atelectasis, or secondary infection, recurrent infections, or any other features. So,
you would love to discuss with the referring physician or pulmonologist to take an opinion whether why this persistent opacity is there in the lung, or is there any some clinical input probably may be required. What do you say?
Right, sir. History is very important, right? What was the patient doing when they started, or what is the history, like the patient is fine or some underlying condition like schizophrenia or something like that is with the patient. So that also is important.
Right. So another important thing, Dr. Nikhil, when we look now in the literature or even in WhatsApp or Telegram, whatever app, artificial intelligence, Meta has into our daily life. Without artificial intelligence, it is becoming, very difficult to survive. Whether you agree or not, it is the order of the day is artificial intelligence. So is there any role? Because if you see the incidentalomas or solitary pulmonary nodules, so even at Apollo, Hyderabad, we are doing a wonderful study on this. As soon as when a different scan, like abdominal scan, is being performed, if the lower lung fields shows some SPN, it gives a red flag just based on AI, artificial intelligence. What is your take? Whether artificial intelligence can have an impact on identifying these airway foreign bodies at the earliest?
Artificial intelligence can definitely help, sir. Like, why is there this infection which is occurring in this particular location only, the lung, right? So that ways it can help, or the HU values, which we generally maybe sometime we skip to take the HU values, which can be automatically taken by the AI.
Right.
So that also can help, and there are many other factors which can help. So we definitely a study can be devised.
Right.
As of now, I don't know if there is any study in this
area. Right. So really appreciate for your answers, Dr. Nikhil. But before going to next question, I would love to take, in continuation of Dr. Sameer's response, what is the role of imaging in differentiating between organic versus inorganic?
So the inorganic foreign bodies are generally radio opaque, so they are very easy to look. For example, there is a coin or a small part of a metal. Also, the inorganic foreign bodies give artifacts on CT as well as on MRI. So there's streak artifacts which can be seen on CT, susceptibility artifacts which can be seen on MRI.
Right.
Organic foreign bodies are difficult to see, but we can, if we have a high degree of suspicion that there may be a foreign body, so we can look that there is something out of the ordinary there, that some tissue, something is lying there which is not normal tissue. It is causing bronchial cutoff. It is, and after that there is expiratory scans. We can help a lot.
Right.
So there is like air trapping. Also, in adults, more common is atelectasis. These findings point towards some kind of foreign body which is not inorganic or metallic. Even glass looks opaque on CT and X-ray.
Right. So we should have a low threshold, of identifying more for organic, and then, as Dr. Nikhil clearly mentioned, it is clinical history is very important. Radiologically, correlation along with the clinical history. Sometimes maybe artificial intelligence, which, as per Dr. Nikhil says, there is no study devised so far in airway foreign bodies. I'm sure hundreds of delegates are listening to this webinar. Anyone across India can take up this study, and then let's see that what is the role of artificial intelligence in airway foreign body evaluation. Thank you, Dr. Nikhil. I would love to have Dr. Raju now. Okay, Balu, okay, you have been practicing rigid bronchoscopies since the time I know, in the sense way back from 2009, 2010 onwards, you are practicing. What is your choice in deciding whether it is flexible bronchoscope or is it rigid bronchoscope? How do you choose, particularly in pediatric cases?
Yeah, thanks, Vijay. I started my foreign body extractions with the rigid bronchoscopic system, but unfortunately, I started with the older system where there was no telescopic view. The only way you can extract the foreign body is to see through the pinhole of the proximal part of the rigid bronchoscope and extract it. And that's how I have learned from my mentor, who's an ENT surgeon. That's how he practices still now.
Right.
So he has experience more than 50 years. But once this newer system has come into place, it was very, very easy to perform a rigid bronchoscopy. For me to, if you ask me, if you give me a choice whether should you do a rigid bronchoscopy or a flexible bronchoscopy, my 100% of the times I just go with rigid bronchoscopy. One, the major advantage is with the ventilation. See, if you want to perform a flexible bronchoscope, you need to take care of the ventilation first. Either you need to secure the airway either with a supraglottic device or an endotracheal tube, and then perform the flexible bronchoscopy. You just can't perform a flexible bronchoscopy for a pediatric airway foreign body straight away, because you need to focus on ventilation part first, then focus on performing the procedure. So, whereas if you perform a rigid bronchoscopy, the greatest advantage is ventilation will happen with the bronchoscope. So, that's the greatest advantage I feel. One, you're securing the airway. Two, you're ventilating the child. Three, that's the best tool available to extract the airway foreign body. So, my takeaway procedure at any point in time, I generally don't think twice to perform a rigid bronchoscopy, because for me it is easy to perform a rigid bronchoscopy than performing a flexible one, because one, you need to secure the airway first, then think about ventilation, then perform the flexible bronchoscope. For me, you just pass the rigid bronchoscope, anesthetist will take over the ventilation. It doesn't take much time, and straight away you will see the airway foreign body and you decide what you have to do. Let us think that your rigid bronchoscopy is not able to retrieve the foreign body. I switch over to a flexible one. Why? How? Don't remove the rigid bronchoscope in the airway. Leave the rigid bronchoscope as a conduit where you can perform a jet ventilation with the rigid bronchoscope. And in the same sitting, you just pass a flexible bronchoscope through the rigid bronchoscope and extract the airway foreign body. I feel this is the easiest way and most fastest way for extracting an airway foreign body. And this is what I have learned in my practice. Even when, as a starter, you always feel that no, I cannot perform a rigid bronchoscopy, it is too difficult. But believe me, if you have seen somebody performing a rigid bronchoscopy with the older system, then I think you are blessed to have a newer rigid bronchoscopic system, which is far, far easier to perform than with an older one.
Thank you, Dr. Balu, for such a detailed explanation. Now, I would like to take your good friend, our good friend now from today onwards, Dr. Vijay Kanth. So, what anesthesia measures or support as a basic support system do you need, sir?
For flexible bronchoscope, we usually do under spontaneous ventilation with supraglottic airway device. So that is okay. But for rigid bronchoscope, either it is apnea ventilation or through that we'll do with Bain circuit or jet ventilation. So the only thing is the continuation of anesthesia is not through inhalational agent, because it will leak.
Right.
Usually our general anesthesia, we induce with IV and continue with inhalational agent. But
Right.
here it is not like that. So we have to go for intravenous anesthesia, bolus doses, and jet ventilation.
Right. So you mean any particular reasons that you don't prefer inhalation anesthetics?
Leak in the system, because it is not, system is not leak proof. It is detrimental to performing people also.
Even
because it will leak
professionals will be affected with the medication. Right, sir. And as Dr. Balu and Dr. Vijaykanth has rightly said, the biggest disadvantages of those pulmonologists who got so far trained in India is our people or our teachers, they don't train to do the bronchoscope under GA or total intravenous anesthesia. That is the biggest drawback. You have a foreign body that is impacting sometimes even in central airway. You just go with a bronchoscope, whether it is rigid or whether it is flexible, okay, without giving proper anesthesia. So anesthesia, Dr. Vijaykanth says very clearly, so anesthesia plays a very, very crucial role, and apnea ventilation and total intravenous anesthesia is what sir's choice. And one more question, sir, do you give blocker as well? Obviously.
Huh?
Once you got the control, neuromuscular blockade is mandatory. Once you
definitely for rigid bronchoscopy, definitely I'll go for.
Okay. So which blocker you generally prefer, sir?
No, for intermittent apnea, it is scoline. But usually nowadays we are not using scoline. It is always vecuronium only. Vecuronium or atracurium. In childs, we use atracurium. In adults, it is vecuronium.
So, is there any choice differences between this vecuronium, atracurium, and cisatracurium as well, sir?
Below 6 months, the liver is not mature enough to handle
And
the vecuronium. So,
sir,
atracurium and cisatracurium better choice. Atracurium got some disadvantages of histamine release. So, cisatracurium is the safest among all these things for
right.
children below 6 months.
Thank you so much, sir. Thank you so much. And coming to again Balraju, back to Balraju. Okay, for impacted foreign bodies, how do you handle Dr. Balraju? And then do you depend more on a single tool, or what is your thought process when you come across an impacted foreign body?
Yeah. So usually in impacted foreign bodies, usually they are long-lasting foreign bodies. Usually there will be a more than 2 to 4 days time. They can be more than 6 months also. We have instances where we have removed a foreign body after 2 years. So most of the time, these impacted foreign bodies, it depends upon what is inside the airway, what is proximal to the foreign body, and how is the impacted foreign body, and what is distal to the impacted foreign body. So if there is more granulation, if there is stenosis, so you need to address that first, then address the foreign body. So if there is a granulation, you need to debulk the granulation. If there is a stenosis, we need to try to remove the stenosis, either use an electrocautery to gently dilate the stenosis first and try to extract it. That's the first point. Second point, if there is no proximal issues, no stenosis, no granulation, nothing, but you only see there is a foreign body which is impacted. So now it comes whether there is some space around the foreign body or not. If you have any kind of space around the foreign body, the best tool would be either a basket or a balloon. So you pass the basket or balloon distally, inflate it, I mean, to open the basket or to inflate the balloon and dislodge the foreign body. So if you can dislodge the foreign body, now it will be very easy to extract the foreign body with any tool possible. So that's the second point. So third point, now there is no amount of space around the foreign body. So now you can't pass any tool behind the foreign body to extract it. So now whatever has to be done, you have to do it proximally. So now you have a choice of two options. One is to do a piecemeal extraction. You try to bite with the biopsy forceps. Now there is a greatest disadvantage here. When you're doing this, there is high chances that you will push that foreign body deep inside down. Couple of instances we have done the same issue, but you have to be very gentle in trying to extract the foreign body. If there, especially if there is no space around the foreign body, you need to bite it properly and use the best tool possible to grasp the foreign body. That's the third point. The fourth point is, now you used your forceps and you're not able to do anything. The last option is to use a cryo. If it is an organic foreign body, you can try to freeze the organic foreign body with your cryo probe at the center and try to extract. Most of the times you can extract it. There are two things. One, the proximal issues are taken care. Two, and you are able to dislodge the foreign body. If you can able to dislodge the foreign body, then you can extract it with any tool possible. So this is what I feel. I had two instances where I could not extract with any of the tool, whatever there. So we need to do a bronchotomy to extract the foreign body. One was a tamarind seed and one was a very bad betel nut.
Right. So what Dr. Balu says is, as we were discussing, we have discussed clearly, for impacted foreign body, disinfection becomes very important. And then sometimes you may use cryoprobe. Okay, sometimes you have to go and then take it piecemeal. Sometimes you may encounter a lot of bleeding, and sometimes you may left over with you have to say that this foreign body cannot be extracted and hand over to the surgeon. Now at this moment, okay, already Dr. Sukhram is really angry on me. The webinar has started already 30 minutes past. The discussion is happening very good, but I haven't involved him so far. Now, Dr. Sukhram, please come over. Please let me know. So, in such a impacted foreign body, okay, what do you do? What are the various things that you can offer to our patients?
Thank you, Anna. I'm not angry. I'm just patiently listening the academic discussion. surgeons are mostly non-academic. They don't have brain. So the if impacted foreign body, the mostly surgeons is required when the foreign body is not being taken with the rigid bronchoscopy or whatever the available thing which is being used and not being taken out. Now, when we look at the airway anatomy, where it is, if it is main trachea or it's into the main bronchus or into the lobar bronchus or into the segmental bronchus, or what is the type of foreign body which is there. So if it is mostly when we get these sort of like in trachea, which is so much impacted and is causing tracheal stenosis. Now, in that case scenario, we need to go and resect the trachea and do the end-to-end anastomosis.
Right.
Because there is no point we can take it out, open the trachea and take out the partial repair is not possible in that case scenario. So the mostly it will be like impacted and we have to resect the two end and then do the resection anastomosis. Now coming to the part where mostly it happening like in the left main bronchus that the mostly foreign body get stuck. In those case scenario, if we have the enough length in the bronchus and we are able to rejoin again, then would like to do the sleeve resection, which we call it is the bronchus end-to-end anastomosis. But for that, we need to have the distal lung should be healthy. If distal lung has gone and there is no healthy lung, then doing anastomosis will not be helping us at any cost. And going to the downwards trend, like the lobar bronchus, mostly if the foreign body is being impacted and not being recanalized with the help of rigid bronchoscopy or the bronchoscopy, in that case scenario, there is no point of looking for the lung saving. There will be like removing the lung. And if that is there, it is causing the lung abscess or something like that, then in that case scenario, let's say infective pathology, we have to take it out. In the certain situation where the like sharp bodies are there, sometimes we see needles or something like these foreign body which is being trying to extract and they has gone into the lung parenchyma. So in that case scenario, or they are partially into the trachea or airway and partially into the lung, that case scenario may not be requiring the lung resection or may not be requiring the trachea or bronchus resection. We just take it out, try to take it out with the lung resection, maybe partially segmentectomy or something can sort this problem.
So wonderful explanations, Dr. Sukhram. So, but let me ask you, what is your time frame for lung sparing surgery? Like if there is a collapse for this much time, say about 2 weeks or 4 weeks, what is your experience and then what is the literature says?
Sir, in our experience, like lung can be collapsed for the we have operated patient whose lung was collapsed for 2 years. But and there was a patient whose lung was collapsed for 6 months. We knew it because the scan was there available, and it is 6 months the lung was completely collapsed. The girl was unaware of things that lung is collapsed. So everybody was thinking it's a pneumothorax, and chest tube was placed, and then later bronchoscopy was done and find out that it's something is there in the main bronchus.
Right.
Now we do usually it's a acute situation, then it's maybe 1 week or 2 weeks. But the dictum is when we go on table and we palpate the lung, if we see the lung is healthy and it's not consolidated, bronchoectatic patches are nodulity is not there. So in that case scenario, we feel it that the lung is healthy. Otherwise, we ask our pulmonology colleague to do some hole and put some air into the distal lung. And if lung is getting expanded and we see it, yeah, it is getting expanded, then we are happy that yeah, this is a good guy for lung preservation surgery. Otherwise,
really wonderful explanation. So till MBBS, I remember abdomen is a Pandora box. In fact, it's not abdomen, it's thorax.
Yes, sir.
Thorax is a Pandora box. And then until you go inside, have a first-hand feeling how the lung looks like, it is very, very impossible to say till that point that this lung can be saved or not. I'm sure, absolutely brilliant inputs. I loved listening to you, Dr. Sukhram. And let me call upon Dr. Samir. Samir Bhai. So, Dr. Balaraju has clearly mentioned about he prefers rigid bronchoscopy, of course, additional tools for disimpaction. what is your choice? Okay, do you also prefer rigid bronchoscopy, or do you have your own special focus towards flexible? What is your choice?
Sir, in our unit, we have both flexible and rigid bronchoscope. But for foreign bodies, we usually prefer the rigid one, sir. Along in sometimes we use both. So there are a few advantages of flexible bronchoscope. That is, it is less invasive, it is easy to perform. Then visualization is much better with the flexible bronchoscope, and of course, it is flexible one.
Right.
But there are few disadvantages, like it has limited grasping ability. Then it is also having risk of foreign body displacement. Then limited suction capability. For rigid bronchoscopies, the advantages, like it has better grasping ability, and we can have a controlled airway with the rigid bronchoscope, and we have a effective suction with the rigid bronchoscope also. And we can do therapeutic interventions with the rigid bronchoscope. That is, we can use the laser or cryo with rigid one. But disadvantages with the rigid bronchoscope are, it is more invasive. It requires techniques, specialized training and expertise. And but also it has disadvantage, like limited visualization with the scope. Rigid
You
bronchoscope.
cannot reach beyond, certain point. Beyond the central airways, you cannot reach with rigid bronchoscopy.
Yes,
That's
sir.
another major
Yes.
disadvantage. I totally agree with you. Now, last week, me and Dr. Balraju was at APSCON Nellore, AP State Conference. We were discussing. There is one person in Telangana, that is our Dr. Venkat Tummuru. Okay, his dicky is a Pandora box. Like, you see his car dicky, if you open, okay, what not every instrument is there, and he is available round the clock over phone to say that to save kids, okay, they may be saturating 60, 70 without hesitation, with proper counseling and then proper, steps. He took many tens and tens of foreign bodies in this part of the country. Dr. Venkat, your inputs, please. So, what do you carry in your car?
Mainly, most of the times, as you said, my dicky carries one small light source, one what you call small camera.
Right.
Otherwise, I have that stores
Right.
one camera, and pediatric flexible bronchoscope and pediatric rigid instruments. Most of the times, I have them.
Right.
And whenever I get a call, last time I was telling at Yashoda, we have become like a snake catchers. One snake is at my home, please come, sir. We have become like that only. So if any call comes, then initially I talk to pediatrician. Most of the cases they referred by pediatricians only. I asked the pediatrician, "Sir, what is the case?" Sir, I unable to intubate. It looks like foreign body only. If you can come within half an hour, I will try to manage with bag and mask. Otherwise, we'll intubate. So whatever the situation, you take care. By that time, I will come. I will ask pediatrician to arrange one anesthetist. 2-3 instances were there. Anesthetist was not available. Patient was becoming bad. Pediatrician only has given anesthesia, including what Vijay Kanth said, scoline. But in one case, patient was very bad, throwing seizures, so scoline was not given. Directly intubated with explained all very bad prognosis. Intubated with rigid bronchoscope, find out one big tamarind seed at the carina level. Successfully retracted.
Wonderful, Dr. Venkat. You're doing such a human services in this part. So really hats off to you and your dedication. And coming to next important question, Dr. Balraju, have you ever got to use this magnetic probes, and your comments on forceps and then snares in extracting of foreign bodies?
Yeah. The first question, the magnetic forceps, I've only read about it, but I have never seen it. My good friend Dr. Hari has used once. He just got from a gastro colleague a magnetic gastrobiopsy forceps, and he tried to use it. But I don't have any experience with it. Lucky, touchwood, till now didn't have to use any magnetic forceps to extract any of the metallic objects. Regarding the accessories, what you spoke about regarding the baskets and if I am not wrong, snare you asked or
forceps and snares.
Yeah. So usually I don't use snare at all unless and until it is really mandatory. Basket will do justice. So the first tool of choice is a basket, especially in pediatric population. So what we need to focus is on a 1 mm basket. So this is very, very important. If you don't have this basket, I think you should go and get this basket. This is a 1 mm nitinol basket, 4-wire nitinol basket. The advantage is so because it has a very, very thin basket, it can be easily passed through a 1.2 mm working channel bronchoscope and also in any of the working channel bronchoscopes. So because as you know, once you go to a pediatric bronchoscopy procedure, we don't know whether how the baby is there, whether there is an endotracheal tube, whether there is a supraglottic airway, or you need to do a rigid bronchoscopy. So we don't know what is the airway situation. So if you have a basket and a flexible bronchoscope, the basket of 1 mm is the best choice. So I usually say this, get a 1 mm nitinol basket. There are two types of basket. One is a proximal opening and the distal opening. What we usually do is a distal opening basket. The proximal opening basket, okay, it is good, but I feel that I don't say that you should have it, but I only feel that you should have a 1 mm distal opening basket. That is for sure the first choice. And the next is the balloon for disimpaction, and next is the forceps. The forceps, you can use your regular biopsy forceps. Our regular biopsy forceps is 1.8 mm dia, so it can go to a 2 mm working channel bronchoscope. But if you are passing in a pediatric bronchoscope, that is 1.2 mm working channel, you don't have a forceps. There is a 1 mm forceps available, but believe me, it has very, very, very less significance because it is so small. It is very, very difficult to catch the foreign body and to extract it also. I feel I have used only once in extracting a distal airway foreign body where my regular forceps was not able to deploy. I had to use a 1 mm biopsy forceps to catch over an foreign body. That's an LED bulb, to extract it proximally and to get it with another biopsy forceps. So this is what I feel. Snare I usually don't do. I feel basket will do your job. You don't have to get a snare for it.
Quickly, Venkat, please comment on have you ever used cryoprobe in extraction and what is your inputs?
Sir, only in one case, in the right upper lobe foreign body was there in 3 years old kid. Just to dislodge it, I tried all methods but failed. But just to dislodge it, I tried in one case.
Right.
But most of the times I use rigid only. And as Bala sir said, what you asked about that magnetic forceps, this one. I tried for one baby, 4 years baby, daughter of what you call shepherd. He used to give injections to his sheep with small needle. He kept that and she aspirated. I tried. I have that magnet forceps, so I tried. But the thing is, it won't touch the tip.
Right.
In the magnet was holding at the center. So unnecessarily, I have injured the trachea because it was coming out and pierced the trachea. So I have to again use that rigid forceps and getting it back and hold the tip. Yeah, push it down and holding the tip again and securing it. But magnetic, these are all fancy, but most of the times I think it won't work.
So let me share one quick experience of mine of using magnetic probe. See, I got it ready. I got it as Balu said. I got it ready for my intrapleural foreign body, a sewing needle, which we published in Lung India as well, almost 7-8 years back. So we got it ready, and then once I went into the thoracoscope, through thoracoscope into the pleural space, it got completely impacted there. And then the magnetic probe has got no role, and I have to dissect and then pick it up with the regular conventional biopsy forceps and then take it off. So that's how magnetic force, as Dr. Venkat rightly mentioned, it can be a fancy thing. It need not be of any major role when you have, as Dr. Both Balu and Venkat commented, baskets available, balloon catheters available, cryoprobes available. So magnetic probe is a fancy item. So coming to Dr. Samir Bhai, I have heard sometimes, okay, some foreign bodies, you need not go aggressively and then do bronchoscope and then retrieve it. Though you know that there is a foreign body is there in the airway. You give sometimes steroids and then antibiotics. When do you do that job? And then in which scenarios it has got helpful? After Samir comments, I would like to take the inputs from Dr. Balu as well.
Hello.
Yeah.
Yes. So you are asking me the role of
steroids and antibiotic. Okay, in a stable airway foreign body, which can help in easy extraction.
Okay. So in case of long-standing airway foreign bodies, steroid can play a role in managing the condition, but there are limited use, and it should be considered case by case basis, sir. Okay. So purpose of steroids in few patients, it may reduce the inflammation, that it decreases the inflammation and swellings in the airway, so which can develop a response, which can be developed as a response by the foreign body, and it also relieves airway obstruction by reducing the inflammation. So, but there are limitations and considerations of using the steroids. So there are means no substitute for removal. If there are no substitutes for removal, then steroids means do not replace the need for removing the foreign body. The foreign body must be removed surgically or through the interventional procedures. Then risk of by use of steroids, it reduces the symptoms, that it masks the symptoms and makes it difficult to assess the patient's condition, sir. Right. Then there are potential complications of steroids, that is, it may cause osteoporosis or infection. But we use steroids in severe airway obstructions. If the patient has severe airway obstruction due to inflammation and swelling, until the foreign body is removed, till that time we give the steroids, and patient is very dyspneic and patient is having respiratory distress. And if we unable to remove the foreign body, in those cases, we can give the steroids. But steroids may be used to manage symptoms and prevent further complications. But in most of the cases, if the patient has aspirated the foreign body acutely, in those cases, we usually give small dose of steroid. But in most of the patients, we do the bronchoscopies, rigid bronchoscopies with antibiotics.
Okay, right. Thank you, Dr. Samir. Balu, any quick response from you?
I just want to share one funny story.
Exactly. I want to listen to this story because you shared with me once.
Yeah, so this was literally around 3-4 years back. So this was a story about a 2-year-old child. So who came all the way from a distal part of Vishakapatnam. So came to one general hospital. So was being treated as pneumonia for 7 days. But there was absolutely no improvement after treating for 7 days, still persisting fevers, breathlessness, cough and everything. They got a chest CT, and chest CT was suspicious of foreign body. So then referred to 2 more hospitals for extraction. But unfortunately, could not be done. So the baby stayed for another 5 days. So I think in this 5 days time, they started steroids. So after the 5th day, probably on 6th day, the baby came to me saying that this is the story and this is what has happened. We got admitted, all these things. And I said, okay, fine, no problem. We'll post you tomorrow. you please come, we'll extract the foreign body. So we posted everything. Next day, baby comes to the hospital saying that, sir, we have removed the foreign body came out, came out. So what was the trick was? The trick was they used steroids. So that steroids, the baby had very significant cough. So with that cough, the foreign body came by itself. So this was a funny story. What I still remember.
But
He
you
used
still need to
steroids.
do an airway examination,
Exactly.
to check
But
any residual foreign body is there or not.
patients don't listen to you. Believe me, even if you tell them, even if you tell that patients won't listen to you. And finally, I didn't do a bronchoscopy for the child.
Right.
And after that, I inquired with the pediatrician. They said that baby is absolutely fine, so they just went off. I said, okay, fine.
Fantastic. So sometimes no interventions becomes a good intervention. So let me talk to Dr. Vijay. Sir, anytime did you take the help of positioning a patient in particular position while retrieving the airway foreign body, sir?
For rigid bronchoscopy, we usually put a roll under the shoulders so that the pulmonologist can pass the rigid scope.
Right.
But retrieval of the foreign body, it's always taking the help of gravity,
Right.
head down position.
Right.
One way it helps, it will come down. And another way, if the pulmonologist slips the foreign body, it won't go distally. And
Right.
another thing, in any bronchus, it is there, the tilt also it helps by gravity. If it is left side foreign body, little bit up on left side,
Right.
and right side foreign body, it is little bit up on right side. That's all. So gravity
So
dependent.
the way you are speaking really is, I must appreciate your expertise is, it's like a cakewalk. But I'm sure it is not cakewalk. It's only experience that made you speak like it's an easy thing. It's not so easy, my dear friends who are listening across India. It is not so easy. But again, please take these very, very important inputs from the experts. When you are retrieving the airway foreign body, please try to keep the position slightly head low so that the airway foreign body, while retrieving it, will not slip into the distal airway again. Thank you, sir. Thank you so much.
Thank you.
And Balu, again, coming back to you, before coming back to you, Balu, there is a question from Dr. Mahesh Kumar Mishra from Rajasthan, Jaipur. He is appreciating absolutely phenomenal discussion that is happening. Thank you, CCI. And this question is aimed at Dr. Nikhil. Nikhil bhai, please let me know what is the indications and contraindications for when you are suspecting foreign body and you want to do a MRI?
Sir, generally, if it is a metallic or a ferromagnetic foreign body, MRI is absolutely contraindicated. And other things in which it is absolutely contraindicated is an ocular metallic foreign body. And if the patient has a pacemaker, so we should avoid it in metallic foreign bodies. But some organic foreign bodies like peanuts, which I also mentioned in the talk, because it is fat rich, so it has a fat signal intensity. So it is very good in peanuts and sometimes also in wood foreign bodies.
Right. Thank you. And then any role of low dose CT in your practice?
Sir, there is low dose CT.
You discussed, I remember, just for the sake of refreshment. Okay, please.
Sir, nowadays there is ultra low dose CT, which is even better than low dose CT. So the ultra low dose, like in X-ray, we have 0.01 to 0.02 millisievert radiation exposure. The ultra low dose CT has 0.4 to 0.6. So, and HRCT's chest is around 6.8 millisievert. So, that much of a difference. Ultra low dose CT, it is very interesting tool to use. They use a thin filter in it, and the images are very, very clear.
Right. Right. Thank you, Dr. Nikhil. Dr. Nikhil is guiding whenever there is a airway foreign body which is ferromagnetic. Please avoid prescribing MRIs for whatever the reason. And second important thing is, so usage of low dose or ultra low dose CT is the order of the day to reduce the radiation that is being delivered to the patient. And coming to Dr. Balu again, Balu, in case of sharp objects, something like, as Dr. Venkat was mentioning, some sharp pin or something like that, or blade, which can cause injury. What is your line of thinking and execution as well?
Yeah. Before I just start, I just want to share one experience with Dr. Vijay sir, because the previous question was focused on positioning of the patient while extracting an airway formula. I just want to share one experience. So this was literally around 5-6 years back. This was a 3-year-old child presented to an pediatric OPD with history of difficulty in speaking and difficulty in breathing, and also drooling of secretions in the mouth. So these are the three symptoms the baby presented. So as usual, the pediatrician has examined, couldn't find anything, did a chest X-ray, couldn't find anything, did a CT scan, couldn't find anything in the chest. So what happened was, so the pediatrician was very skeptical. So what should we do? Because we don't know what is the cause of this whole thing which is happening. So this was posted for bronchoscopy, and I was called in for doing a bronchoscopy for this child. So Dr. Vijay sir was giving anesthesia for this child. So usually if you are suspecting an airway foreign body, we usually don't do a rigid bronchoscopy. We just do a flexible bronchoscopy under sedation. So just to examine the airway. So just go inside, examine the vocal cords, larynx, airway, subglottis, everything. So you examine and you come out. So while performing, so I usually make sure that I usually see the two nostrils, one from this side, from other from this side, so that I don't miss anything in the nasopharynx. So I still remember this case, we examined from the both nostrils. We went inside, that nothing was in the nasopharynx, nothing was in the oropharynx, nothing was in the laryngopharynx, nothing was in the airway. So we didn't know what was the reason why there was pooling of secretions in this case. So what happened was, so I was writing a note saying that everything is normal, and Dr. Vijay sir suddenly said, "Balu, just wait, don't pack up. There is something there. I'm just going to show you." So what he has done was he extracted that foreign body which was dislodged inside the nasopharynx. So this was a cartwheel, white color cartwheel, what we have in the toys, the small cartwheel. What was happened was, it was lodged in the nasopharynx in such a way, when I was passing the bronchoscope from either of the nose, it went through, I could not see that white cartwheel in the nasopharynx. So that was the reason why there was pooling of secretions in the mouth, and also difficulty in speaking, and also difficulty in breathing. So why the position is important? Because he was holding the head and trying to pass the Riles tube, because usually once you give anesthesia to evacuate the stomach contents, because somebody is coming out from the anesthesia, there is high chances of vomiting. So he was passing a Riles tube. While passing a Riles tube, that foreign body got dislodged and went inside the oropharynx. So once it went inside the oropharynx, it was difficult for him to ventilate. So at that point in time, he could visualize there is something there in the oropharynx, and he extracted with an McGill forceps. So I feel that anesthetist plays a very, very crucial role in this case. And all credit should go to Dr. Vijay sir, because that day he saved my life, not the baby's life. Because I was about to write a note saying that nothing is there inside the airway or in the nasopharynx. To my luck, he has removed that airway foreign body. I was very, very happy. And coming to a question regarding how do you approach sharp objects? So there are two things. One, so most commonest sharp objects, what we see are LED bulbs, wires, all these pins or chicken bones. Usually these are the sharp objects what we encounter inside an airways.
In Hyderabad, the
Scarf pin.
scarf pins, very
Yes.
common.
Yeah, pins, all these are usually noted inside the airways. So the best way tool is first see where it has lodged it. So usually it will be inside the mucosa. Most of the times it will be lodged inside the mucosa. So the only way to get it out is to hold the lodged part and push it distally. So once you push it distally, usually you will dislodge it. So once you dislodge it, in the same way, you need to safely keep that sharp object inside the rigid bronchoscope or the endotracheal tube, one of it. If you are using an endotracheal tube, just keep that sharp object inside the endotracheal tube. Or if you're using a rigid bronchoscope, keep that sharp object inside the rigid bronchoscope. And when you're extracting, make sure that you extract the whole unit as in toto, so that nowhere you will able to cause injury to the mucosa of the trachea or the bronchus. Because I had instances where I had to extract safety pins, needles, scarf pins, what you have cardboard pins. You remember you put that pins on the board, cardboard pins, LED bulbs. So these are very dangerous objects. One wrong move, you will repent for your life, because the next call will be to your thoracic surgeon. So one wrong move, you are going to
may
rip
not
off
have
that.
time to call surgeon as well.
So
I totally
one
agree.
wrong move, you will rip off the trachea. So there will be significant amount of bleed. Within no time, you will have mediastinal emphysema, and within no time, you lose the airway. So I am very skeptical when you're addressing in sharp objects. Even if you take time, see, most of the times they are not obstructive foreign bodies because they are sharp objects. Usually the airway is free, so there won't be any problem with ventilation. So don't get panic. So you don't have problem controlling the ventilation. Your problem is to secure that sharp foreign body. So once you secure it properly, then you can safely extract it. That's what I feel.
Thank you, Dr. Balu, for detailed explanation. Now I call upon Dr. Venkat for how do you handle when you dislodge the foreign body and then you could get it up to the subglottic, and then since it's swollen up and you could not take it from subglottic region. Venkat, over to you.
Sir, in one or after dislodging it, if you hold the foreign body properly, for if it peanut, not to try to hold it at the center, try to hold from the top, and at the subglottic level, you can manipulate the scope. Vocal cord will be like this. So
Right.
you can manipulate the scope and take it out slowly. In 1-2 instances, there were instances at subglottic level got stuck up, unable to remove. So in those cases, we have to push down the foreign body, talk to anesthetist after once the baby gets stabilized. Mainly, most of the times, bradycardia is the issue.
Right.
Once the baby gets
Oxygen
stabilized, and try to remove it properly by manipulation is important at the subglottic level.
Right. Maybe sometime push it back and then take it piecemeal.
Yes.
So,
hold it properly and take it out.
So you, Balu, everyone, Samir, have done your best job, but still you could not take it. So now I request Sukhram Anna to comment on, do you venture into doing a tracheostomy or something like that to retrieve the airway foreign body in such scenario? Dr. Sukhram?
Yeah, you just have to unmute it.
Hello, Ji sir.
Yeah. But
sorry, I missed the question.
No. See, when a airway foreign body, which Dr. Venkat is or Dr. Balraju is retrieving it.
Yes, sir.
And, it reached to subglottis and it is playing there. It is you do whatever maneuver, whatever Dr. Venkat has explained clearly. You are unable to retrieve the foreign body. What do you do in such scenario? And do you prefer, I'm giving a clue, do you prefer to convert into a tracheostomy or ECMO, or what do you do?
Sir, if in the acute situation where I feel that we may lose the airway and it's a complete obstruction or near complete obstruction, where I would like to do the tracheostomy in this situation. Mm-hmm. Because ECMO will take hour or so. It's not being ready in every hospital, and it is even for putting ECMO, it requires at least half an hour or maybe more than that to put in that patient. So rather than that, tracheostomy is the easy solution. Do the tracheostomy, and then we can do it electively this situation. But since we know, because bronchoscope is inside, so where exactly this foreign body is. So while putting needle, I can see it. Yeah, I'm distal to the foreign body, and we can do the tracheostomy maybe in the little lower down, and put the tracheostomy, and then we have all the time to take out this foreign body. We can crush there and then take it out, or maybe other way to put the rigid, or because there is a situation which we made the emergency situation into the elective situation, and here we can take it out, sir.
Thank you, Dr. Sukhram. And is there any, Dr. Venkat, is there any assessment scores available for pediatricians to think of the foreign body aspiration?
Yes, sir. Usually, foreign body assessment score, what there are 10 points. One is choking episode, it carries 2 points, but most of the times it is mainly goes to the history only.
Right.
Choking episode, 2 points, and exposure to nuts and seeds. Mainly, this is regarding pediatrics.
Right.
Exposure to nuts and seeds, and other thing, other point is sudden and persistent cough, sudden onset of cough, absence of fever and rhinorrhea most of the times, and the stridor carries 1 point. Unilateral auscultation findings. This is very important. Unilateral monophonic wheeze or unilateral diminished breath sounds or complete absent breath sounds, and suspected findings on chest X-ray. Most of the times, chest X-ray will be normal only in acute situations. That in those, if it is 1 to 3, that is low risk, and whether to admit the case or we can call the case for follow-up. And 4 to 6, it is moderate risk. We have to, in those cases, we have to go for, better to go for flexible bronchoscopy. And 7 to 10 is high risk. We have to do examination, and we have to go for either to go for CT scan or to go for directly go for bronchoscopy.
So they do really help in clinical management, what Dr. Venkat says. So now there is a comment from Dr. Jayaraman, our good friend from Chennai, senior pulmonologist. Unilateral recurrent pneumonia, which we have to rule out endobronchial foreign body. Absolutely agree with you, Dr. Jayaraman. Okay, Ajay Vasant Lanjevar is mentioning lung abscess when it is delayed resolution. You have to look for foreign body. 100% agree with you. And Dr. Lakshmi Murali from Tamil Nadu commented that magnetic foreign body, any special forceps. We discussed this very clearly. And lot of congratulatory messages on such a unique topic. Okay, thank you all delegates for your congratulations. Your appreciation means a lot for us. And another 10 minutes time is there. Now I quickly go upon, please be very precise. So what are the, Dr. Samir, what are the complications of tracheobronchial foreign body? Quickly, please, as brief as possible.
Sir, for tracheobronchial foreign bodies, the complications can be acute or chronic.
Right.
The acute, like asphyxia, it may cause complete obstruction of the airways. Then respiratory distress, that is, if the partial airway obstruction is there, it can cause the respiratory distress. Then choking, or that is sudden onset of symptoms, that is coughing, choking, or difficulty in breathing, and airway obstruction, which leads to respiratory failure. These are the acute complications. And chronic, like pneumonias, recurrent pneumonia, then bronchiectasis, then chronic cough, then wheezing or asthma-like symptoms, that is unilateral wheezing. These are the complications. Then other complications like perforation, that is, if the sharp object is there and it can puncture the airway or lumen of the airways. Then infection, bacterial infection may cause recurrent pneumonias, abscesses, or empyemas also. Then it may cause the airway damage and respiratory failure.
Right. Thank you, Dr. Samir, for a very crisp answer. now I request Vijay sir, what are the risk factors that you see? Children's we have discussed adequately now. In adults for airway foreign body and when to suspect, sir?
The thing is, usually adult foreign body is rare scenario, but apart from drug abusers and alcoholics, and some neurological problems where airway reflexes are lost, or some altered sensory, and immediately after eating or after drinking, if patient chokes and it continues for some time, and we suspect the foreign body usually.
Right. Quickly, sir, another important question, very, very important question is how does a presence of foreign body will make you think to alter the ventilatory strategies in these patients?
You mean to say in ICU before we take into OT?
Yeah,
Or in OT?
overall, in ICU and also in while ventilating, we discussed already. In ICU, what do you
Yeah, in ICU. But as soon as possible, it has to be removed. If it is, it cannot be removed immediately due to lack of facility or lack of pulmonologist. What we do is, if the baby is spontaneously baby or adult, if they are maintaining on spontaneous ventilation, always better to maintain on spontaneous ventilation with high oxygen. Because mechanical ventilation, as everybody is discussing, there is a ball valve mechanism. A distal emphysema will be there. There is a possibility of air trapping and pneumothorax also. So if at all, if it is required invasive ventilation, we go for low tidal volume, high rate, and high oxygen. And we frequently check the ABG for CO2 retention. According to that, we have to adjust. And in special situations like pneumothorax or some fistulas, bronchopulmonary fistulas, you have to go for high frequency jet ventilation. Normal conventional ventilation will not.
is not permitted. Right.
Not permitted because
Dr. Nikhil, quickly, any role of three-dimensional reconstruction or virtual bronchoscopy in assessment of airway foreign bodies?
Sir, they have a very good resolution, and no anesthesia is required. They are non-invasive, and they are generally acquired similar to CT. So, and 3D reconstruction is possible in virtual bronchoscopy also. So, and also we can look for the parenchymal abnormalities together with the airway. So this is a good modality.
Thank you, Dr. Nikhil. Samir, please let me know quickly, what are the challenges that you face in smaller towns, not in metros? Okay. Dr. Venkat has explained clearly before. Your take, please provide.
Yes, sir. Actually, as I'm working in small town like district like Nanded, so there are limited access to specialized care. Like there are very few pulmonologists. There is no thoracic surgeon at all in Nanded, and there are very few interventional radiologists. Then there are lack of adequate equipments like rigid bronchoscope or latest bronchoscopes. Then CT scans. They are not available at all the time and in all the hospitals. And there are inadequate, means there are very few anesthesia equipments in all the hospitals. Then insufficient training and experience of pulmonologists, and sir, mainly the general practitioners from villages, they have to suspect the foreign bodies. So if they don't suspect, then the diagnosis will be delayed and the patient will come in bad situation in our hospitals. So these are the problems. Then mainly the affordability is the issue, sir, in smaller towns. Then limited ICU or critical care facilities are not there. Then if I have to send the patient to some higher center also, then there are transportation issues are there. Then higher risk of complications are also there if we don't have all the adequate equipments. So these
I was told from our Nanded colleagues, your chances of extraction is close to around 100%. Okay, but really appreciate. Yeah.
Actually, in our hospital, sir, we have nearly all the equipments, like including cryo, rigid, adult, rigid pediatric, then thin bronchoscope also. Then we have trained ICU team and good pediatric anesthetist is here in Nanded, sir.
So
we are able
Samir, what clearly mentioning is, It is not the good intent to retrieve. You need to have a good amount of training in the team, good anesthetist, and also apt equipment for successful retrieval of airway foreign bodies. And last important question to our Sukhram Anna. So, when do you consider, most of the times, okay, do you go for thoracotomy, for sleeve resection, or VATS is good enough? What is your choice?
Sir,
Quickly.
first choice is, yes, sir. Yeah, sir, my first choice is always VATS. Put the scope and see it. If it is feasible, do it. But the first dictum is never harm the patient for sake of our ego that we will be able to do only by VATS or only by thoracotomy. When in doubt, you can go ahead and convert. Conversion is not a loss. It's in good faith. We can convert and do the complete. The primary thing is we have to do the complete job, whether it's by VATS or by thoracotomy or by any means.
So, do no harm.
Do no harms.
So another important video which you have shown after retrieval of that bullet piece, okay, you have done a wedge resection. There is a huge discussion that has happened in the CCI Ultra group as well. What is your take? Do you recommend quite often, or you check that the viability of the tissue is not good enough, so that it may develop future lung abscess? So that's why you have done the wedge resection. What is your take?
So now this is a debatable issue. We have only one chance that we have done the complete removal of the foreign body. Now lung resection should be done or not. If we don't do today and 10 years later we realize we could have done this thing, there is no point of going back and doing it. So this is done in because this guy was young chap. It is some 13, 14-year-old children, and where the lung was being injured, and we can feel it. There is a consolidation and lung contusion was there. So we thought that a small part of the lung resection will not be harming him because there will be complete lung expansion. So we may not be attempting second surgery and leaving him with the bronchiectatic patches throughout his life may be a situation where obviously it's a debatable issue. There's no clear-cut guideline which says that we should do or we should not do. But we felt it we will be helping the children with the part which is already being destroyed. We can do with the intensity.
I'm sure behind your thought process, Professor Arvind sir is there, and under his wonderful guidance and decades of experience, you have done that job. It was really, great job. And please, my dear friends, please ready to conclude your one-liners. First, let me take to my good friend Dr. Balu. One-liner conclusion, please.
Please don't afraid of rigid. So please don't curse it. Rigid is the best system. Please use it.
Thank you. And Dr. Venkat?
Sir, as Bala sir said, rigid is very good system. And about other pulmonologists or ENT colleagues, if you are not unable to remove the foreign body, call your senior colleague. Don't go for egos.
Right.
Patient is more important. And Bala sir can remove foreign body in 30 seconds, but others can't do. But don't think that Bala sir removed within 30 seconds. I took 10 minutes also. But finally, patient is important. Do it safely.
Fantastic. Dr. Samir?
Yes, sir. Sir, for foreign bodies, be prepared for all the situations. Counseling is the most important part. So while before doing the procedures, relatives should be explained all the ways the complications and the surgery may require surgery and the anesthesia complications. So in smaller towns, we have to do all these counseling very well to the relatives. So and we have to be prepared for all the complications.
Fantastic. Dr. Vijay Kanth?
Apart from routine things, from me, for flexible scope, it is IGEL, appropriate set IGEL. And for rigid bronchoscopy, it is jet ventilator. And for anesthesia, total intravenous anesthesia. These are the 3 parts.
Fantastic. Thank you. And Dr. Nikhil?
Sir, expiratory X-ray, low-dose CT, ultra-low-dose CT if available should be done for.
Right. Dr. Sukhram?
Yes, sir. As and when you need, you can take surgeon as your backup team. Is always there to help.
You're all
Obviously,
part of our team, yeah. Okay.
yes, sir.
Okay. Yes.
So as in acute situation like airway tear is there or foreign body is not being resolved with the complete availability of the resources. I mean, you can take the help from the surgeon.
Right. Fantastic. Every great things has to come to an end, and it is my part to conclude whatever they said briefly. No afraid of rigid bronchoscopy from Balraju. No ego, Venkat Tummuru, and adequate counseling, Dr. Samir. IGEL inflexible and jet ventilation in rigid mandatory. Low dose CT and expiratory X-rays. They plays a very crucial role, as Dr. Vijay said, Dr. Nikhil said, and Dr. Sukhram said very clearly, multidisciplinary team, whenever you require a surgeon's presence, okay, they are there to help us. And final conclusion, my dear friends, it is one of the saddest Independence Day for medical fraternity. I must say that. Always prevention is better than cure. But let me share, please allow me to share one slide. Hope the slide is visible. Yeah. What our father of nation, Mahatma Gandhi ji, said very clearly decades back, 70, 80 years back, he said very clearly, the day a woman can walk freely on the roads at night, that day we can say that India has achieved independence. Just touch your heart and then say, did we really achieve that independence? When are we going to give that freedom to women? Give that security to women? It is our individual responsibility, my dear friends. Those who are listening to this webinar, please pass on the message. Respect women, because it is the basic fundamental thing which we need to attain to say that we achieved independence. And these goons, these rapists, aggressors, invaders, muggers, molesters, other anti-social elements in India or across the globe are like foreign bodies. I urge Prime Minister's office to disimpact, remove and crush these foreign bodies to ensure our women, doctors and entire society to feel safe and secure. With this, I would love to conclude today's Independence Day webinar, Freedom from Foreign Bodies. In airway, it is airway foreign body. In India or in across the globe, these antisocial elements are foreign bodies. Thank you, and looking forward to meet you in next week, Thursday's session. Thank you.